Hello, everyone. This is Siddharth Damber from Chicago Arthritis and Regenerative Medicine. Welcome to our webinar today, Regenerative Medicine Treatments for Lower Back Pain. As I begin, if you have any questions, please post them into chat. And as we go through all this, I'll likely cover most frequently asked questions, but please continue to ask as we're going through. And I'll try to catch up on them as, when I get breaks in the talk. Okay, so today's talk is Regenerative Medicine Treatments for Lower Back Pain. So what should you get from this webinar? Number one, you'll learn about the best available non-surgical regenerative medicine treatments for your lower back pain. That includes for arthritis, if you've had a lower back injury, sciatica, degenerative disc disease. What is legitimate, what's not legitimate in the field of regenerative medicine, and the 9 things your physician must know if they are an expert in regenerative medicine, and ways that you can obviously make sure you're getting appropriate care and top-level care. So again, as I'm going through this, leave your questions in chat and I'll get to them as time allows. So the big question is, what would you do if your lower back pain was controlled? How would your life improve? What exercise would you restart? And what activities with family and friends would you participate in? So who am I? To begin with, why am I talking here today? My name is Siddharth Damber, physician at Chicago Arthritis and Regenerative Medicine. I am a specialist in rheumatology. I am also a specialist in image-guided musculoskeletal injections. I've been in practice since 2008. I've been involved in regenerative medicine since 2008, and I've been involved in the Regenexx Network since 2012. The Regenexx Network is the largest network of physicians who are actively practicing and participating in regenerative medicine treatments. So the problems with traditional care when it comes to musculoskeletal medicine, in general, especially when it comes to lower back pain, the usual treatments include pain medications, ice, and rest. These generally mask the pain. There's no attempt to really fix the problem. And really the attitude is you're just waiting for eventual surgery. And the example that I give to people is it would be like if you had diabetes and your doctor told you, why don't you wait until you have your first heart attack or stroke before we do anything else? That's not a good way to treat those other conditions. I think when it comes to your back pain, that's not the right way to treat it either. Problems with pain medications, there's a lot of side effects chronically if you're taking anti-inflammatory medications long-term, including affecting the liver, the kidney, the stomach, heart, and even bleeding. Chronic opioid use for pain. We know there's so many problems with opioid addiction and opioid issues in this country, so that's just not a great long-term option either. The traditional injections that are utilized, steroid injections, they can help short-term, but the problem is that they can damage tissue, increase the risk of infection, diabetes, and osteoporosis. They're not a very good long-term option. A lot of frequently performed procedures by pain medicine doctors include nerve blocks, radiofrequency ablation. While those can give pain relief as well, they do have the risk of nerve damage, muscle weakness. And again, they're not a really great long-term option either. Some issues with other traditional care include for surgery, much higher risk of bleeding, much higher risk of just risk in general, tissue damage, anesthetic risk, cardiac risk. Many routine surgeries are proven to be of questionable effectiveness. Lumbar fusion, which I'll talk a bit more about later on, may help with neuropathic symptoms, meaning numbness and tingling symptoms, but it's not very good at helping with pain. There's just a lot of other risks associated with that, which I'll touch on later on. The disc surgeries, the minimally invasive disc surgeries that are frequently done, they do have a risk of instability as you remove tissue. As much as you can maintain your own tissue, you're better off in terms of maintaining stability and long-term musculoskeletal health. Spinal cord stimulators are a very common treatment that are utilized for back pain nowadays. Again, it's hardware. You're placing hardware into your system. There's risk of infection in that case as well. So lumbar fusion. Lumbar fusion is one of the top 5 surgeries that's performed in the United States. And it's just gotten more and more popular and more used as time has gone on. That's a problem because while lumbar fusion can help with some things, it's really not great for a lot of other things. Namely, while it can help if you have a badly pinched nerve in the back, it's just not very good if you have pain. So some of the problems with lumbar fusion, essentially with the way lumbar fusion surgery works, and the picture on the right is a kind of classic lumbar fusion surgery. They're ones that are even more complicated, involved with even more hardware. They essentially kind of block off the movement that you have between two segments of the vertebrae of the spine. And the problem with that is that in the spine, there's a normal curvature to the spine, and there's a certain amount of normal mobility. And if you fuse this segment together, the same force that's going through the body now has to be displaced elsewhere. And so there's a condition called adjacent segment disease. What that means is that if you have stabilized or fused one segment, then that force is then displaced to a higher or below that level. And it can then lead to those same problems that you're suffering from that one level at those other levels. And so the classic is that one fusion surgery then leads to the next fusion surgery, just because the next level is then problematic. There's evidence that fusion surgery is not better than physical therapy alone for lumbar degenerative disc disease or spinal stenosis. In addition, the evidence out there shows that for chronic pain, that lumbar fusion surgery does still have the risk of maintaining chronic pain, and disability can persist post-lumbar fusion, and that chronic opioid dependence persists despite lumbar fusion surgery as well. So it's not what it's not what it's really cut out to be. It's really not as good of a treatment for pain in particular as what people expect it to be. And the sort of chronic failed back surgery condition is one that is really common, unfortunately, in this country. So in searching for better options, the keys are: how do we avoid side effects, a low risk kind of procedure? How do we also improve the actual cause of the problem? And how do we get long-term improvement as well? Right. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the field of medicine where you're utilizing your body's own cells to treat arthritis, tendonitis, injuries, and back pain. This is utilizing the normal healing process. Essentially, when you have an injury, for example, if you cut your own finger, if you have that small cut, essentially your body responds by infiltrating that area with blood, platelets, growth factors, which then helps to stimulate your own local stem cells, which then helps to trigger that normal healing cascade and process. So after that injury, you have cells and growth factors that enter that area. Inflammation then sparks that cellular repair process. As it turns out, tissues that have poor blood flow do not heal well. So that includes tendon, cartilage, ligaments, disc, labrum, and meniscus. All of these musculoskeletal tissues that chronically over time, if they've been progressively injured or chronically injured, chronically unstable, then lead to progressive damage, arthritis, tendonitis, injuries, pinched nerves, and pain. So regenerative medicine is the process of harvesting those cells, either from your own bone marrow or blood, and injecting those cells under fine X-ray ultrasound guidance into that tissue to then restart that normal healing process. So why regenerative medicine then? Well, it helps with pain reduction, increases function. It treats the source of the problem, meaning instability and inflammation. It's much lower risk and safer than surgery. Much limited downtime post-treatment compared to surgery, minimal time off of work, minimal disruption of regular routine, minimal use of mobility tools in terms of crutches, braces, and it's effective for most musculoskeletal conditions. And for those of us that are involved in this, there's a sense that over time, this will eventually take over 80% of traditional orthopedic surgery, will eventually be managed by regenerative medicine. In the same way that the vast majority of open cardiac surgery is now managed by needle-based procedures by cardiologists. So how does regenerative medicine actually work? So in a number of different ways. Number one, it optimizes damaged cellular health of tissue. If you take a look at damaged cells in a tendon, joint, ligament, or nerve, essentially injecting your own mesenchymal stem cells into that area or your own platelets and growth factors into that area generally leads to those cells working better. What that means is that in a musculoskeletal tissue that's been chronically damaged, you have cells that are not producing the correct kind of proteins and enzymes. By injecting those correct kind of growth factors in cells, you can get those damaged cells to start functioning better by then pumping out the right kind of proteins and enzymes that you see in a healthy joint, tendon, nerve, or ligament. In addition, if you inject your own mesenchymal stem cells into a damaged or overworked or overwhelmed area, those cells will actually replace some of the damaged cells as well. In addition, you can also improve stability. You can improve strength and stability of supportive soft tissue structures, whether that's ligaments, tendons, other soft tissue structures. Strengthening those supportive structures helps with pain and function long-term as well. I'll talk more about stability in a bit. You can also improve chronic inflammation in a chronically arthritic joint or tendon, which you find are enzymes, cytokines of a chronic inflammatory process. These kind of treatments can help to reduce that long-term as well. You can also improve neuromuscular health. You can reduce the irritation of nerves, reduce inflammation in a compressed nerve, and you can also improve stability in the spine to take pressure off nerves as well. So other regenerative medicine basics, is this legal? So yes, there are fairly progressively defined guidelines from the FDA that if you're using your own cells as opposed to somebody else's cells, if these cells have not been significantly altered or adjusted, and if you're injecting these cells into damaged orthopedic tissue, that is legally compliant. There are other ways that this is done, which I'll talk about in a little bit, that are not compliant. So there are some very fine and clear FDA guidelines on this. Another question that comes up, if I'm older, shouldn't I use someone else's cells? And really the simple answer is no. For the vast majority of orthopedic conditions, there's good evidence that using your own live cells is effective. There are certainly risks to using somebody else's cells. Your body's not meant for that. Your body can have a reaction to that. There's also a risk for spreading infection. Note that in the United States, it is considered illegal to inject somebody else's live stem cells into yourselves, with the exception of certain childhood leukemias. Is there an age limit? Simple answer is no. The results that we see for knees, lower back, shoulders, elbows, ankles, and neck are not impacted by age. We've come to realize over time that the outcomes for hips can be worse with age, but for other areas, that does not seem to be the case. What sort of doctor does these treatments? Really, it should be a physician that's focused on musculoskeletal conditions. You don't want to be seeing a plastic surgeon who's injecting Botox and doing liposuction in one room and then jumping in to help treat your back in another room. They don't have the right expertise for that. I strongly think it should be a physician who's really focused on non-surgical treatments for orthopedic conditions. It's a very different perspective that orthopedic surgeons bring to care. Their treatment modalities, while they are appropriate and work for the conditions that they treat, for these kind of conditions where you need to take a mentality of focusing on stability, inflammation, neuromuscular health, that's different than a surgical mentality where you need to cut out damaged tissue or take out damaged tissue and put in a prosthetic or metal or plastic hardware. It's just a very different perspective on how to care for somebody. And I think there's a number of things that really make someone a proper regenerative medicine expert, and I'll talk about those in a bit. So can these treatments help if I've already had surgery? Essentially, yes, except if the joint has already been replaced. So if you've had lumbar fusion surgery, these treatments can still help. And again, that's because frequently people end up having pain that's being drawn in from other areas of that unit. So if you've had fusion surgery, the ligaments can be chronically weakened, that can still be treated. Frequently the nerves around that can be chronically irritated, and treating that can be helpful. And again, of course, treating the facet joints and ligaments at the segments above and below is also frequently needed because those are frequently pathologic as well. My general rules for orthopedic surgery would be, if possible, try to keep your own anatomy. Avoid surgeries that are cutting out tissue if possible. There's a lot of quote unquote minimally invasive surgeries where tissue is cut out. It can leave those areas more unstable over time. And always consider non-surgical options, in particular regenerative medicine treatment options, if you've been recommended surgery. So there are a few concepts in regenerative medicine that are incredibly key and important to understand, and I'll talk about those here. Stability. Stability is an incredibly key concept in regenerative medicine. It's this concept of biotensegrity, where if you take a structural unit and if you take the individual pieces of that, and if you put them in close approximation and compression, that overall structural unit is significantly stronger than the individual units as you would expect them to be put together. Stability is very key. Prolotherapy is a process where you inject your own cells into soft tissue, supportive structures to strengthen and stabilize that area. That's key because when you look at someone who has a chronic issue, you want to make sure that you treat every level and layer that's actually driving pain and dysfunction. And when you really look at someone who has, let's say, a chronic lower back issue, there's layers and depth to treating that. And that starts from not only at the level of the epidural space where the nerves lie, it goes up to where the ligaments are, where the facet joints are, the different layers of musculoskeletal and myofascial tissue as well. And treating all of those layers and depth can make a difference in terms of pain relief and function. Also understand that these treatments are slow acting and that there is a slow progressive improvement over several months. And that progressive strengthening comes over time, does not happen very quickly. And in general, these are much longer lasting results as compared to some of the other traditional treatments that are done non-surgically. So here's kind of an example of what I mean by lumbar stability. Essentially, again, improving stability leads to improvement in pain and function. And you want to treat all layers involved in pathology. This is a nice picture on the right side that shows what instability can actually look like on an MRI sometimes. So this is rarely mentioned by radiologists, but it's something that we see frequently. And where it says normal, this is a normal cross-sectional view of a lumbar MRI. Where I'm circling right now are called the multifidi muscles. That is what normal healthy muscle looks like. As you start to see it infiltrated with this kind of fatty tissue, that is consistent with progressive atrophy in the muscles. That's significant because this is a muscle layer that is the sort of bottom line stabilizer when it comes to the spine. You can see that weaken over time due to either just progressive atrophy of the muscles there, or there's a frequently done procedure called bundle branch block, where you're actually blocking the nerves that are offering sensory supply and sensation to the facet joints. And the problem with injecting that is that while it can help with pain relief, it can also lead to muscle weakness. And so it's key to understand that muscle atrophy is significant because it leads to more instability of that spinal unit, which will lead to more pain. So as an example, in someone who has degenerative disc disease, when you're treating lumbar stability, you want to treat every level: facet joints, epidural space, ligaments, and even this muscle layer, this multifidus muscle. If you've got chronic sciatica, again, treating the nerve is important, but also treating the surrounding tissues that are leading to that instability that lead to that pressure on the nerve. It's an example of a lumbar spinal stenosis case. I'll show some other images in a moment, but it's essentially a 45-year-old man with chronic lower back pain from spinal stenosis. His treatment was he had platelet-rich plasma treatment where we injected into the facet joints, epidural space, and ligament. The picture on the right is a picture of where we're injecting into the epidural space. We use X-ray and contrast to confirm that we're hitting all the right structures as we're doing this. His result, he had a very good result. He's at 75% pain relief. He's been able to exercise and get back to yoga, and he's had a significantly improved quality of life. To see what that looks like on an MRI is the following. So this is his pre-treatment MRI on the left, and this is where his spinal stenosis is occurring. He's essentially the disc is protruding and pushing up against the nerve. This is roughly 6 months later after treatment, where that spinal stenosis is lessened, and that really accounts for why he has so much pain relief. he's had a good result, and he's someone that has had also an imaging result, although for most of our patients, we're talking more about clinical results, meaning pain relief and functional improvement. Orthobiologics. Orthobiologics are the biologic cells and tissues that we inject into damaged orthopedic tissue. Again, utilizing a normal healing cascade to help somebody recover from an injury or to help their pain and dysfunction. Important to understand that you can inject your own cells legally in this country. You cannot legally inject somebody else's live cells in this country because there are higher risks associated with that. And I'll talk about what are some of the other types of cells that are being injected in this country and why there may be issues with that. So the most common orthobiologic treatment that's currently utilized are your own platelets. So after an injury, platelets recruit other cells and growth factors to assist in repair. They utilize inflammation to help repair tissue damage. And platelet-derived growth factors will actually stimulate your own local mesenchymal stem cells, and that is a large part of how they work. So there's really a couple different types of platelet products. There's platelet-rich plasma, where we're concentrating your blood into a very high concentration of your own platelets. That's helpful in higher concentrations to treat joints and tendons. There's platelet lysate, where we take those same platelets, crack them open, and just take the growth factors from that. That's less inflammatory. That's more helpful for ligaments and nerves. The picture on the right shows two different types of platelet-rich plasma. The one on the left is platelet-rich plasma without red blood cells. That's less inflammatory. That's what I would recommend injecting into most tissue. The one on the right is platelet-rich plasma with red blood cells. That's more inflammatory, can be helpful for muscle. I would not recommend injecting that into other types of tissue, however, it's just too inflammatory. If your physician does not understand that difference or does not have that flexibility in terms of deciding which type of product to use or which type of concentration, you need to be careful because you're not going to be getting an ideal treatment for your condition. Really, the right way to do this is that if you have, depending on your condition, depending on your age, depending on your other kind of medical problems, you want to have a treatment that's very tailored to your specific issue. So if you see someone that has more of an arthritic issue and they're older, you want to maximize the concentration of platelets. That takes a much higher amount of blood and a much higher level of concentration. If you're using a prep method that does not offer you that flexibility, and most physicians do not, you're not going to get that kind of level of sophistication or particular sort of specification for you and your condition. That is a really key part to get a better result in patients. This is a case study of a 70-year-old woman who has sacroiliac joint osteoarthritis. She had back pain and hip pain. SI joint related pain can account for roughly 1/3 of lower back pain conditions or back pain patients. In her case, she'd received platelet-rich plasma into the right SI joint. She's had a very good result, 80% pain relief, and also getting back to jogging 5K races, exercising daily, and working full time. Picture on the right, there's the needle, and this is injecting into the SI joint. Again, emphasizing being very particular in terms of where we're injecting cells. We need to be very exact about that. The next common orthobiologic to understand are your own mesenchymal stem cells. So stem cells are the main cell that drives tissue repair and recovery after an injury. Again, utilizing your own cells is not only preferable, because that's what your body properly responds to, and that's where all the medical data really exists, but it's also what is legally compliant in this country. Bone marrow-derived stem cells are legal in the United States. Fat stem cells are not legal in the United States. The chemical that is utilized in order to break down the connective tissue to get to fat stem cells is not considered to be safe for usage in humans by the FDA. You can use fat or adipose for structural support, and I will certainly do that on occasion, which essentially is not, it's not exactly a stem cell treatment. It is, however, a orthobiologic and structural treatment. Other types of stem cells you may be hearing about amniotic or umbilical cord cells, understand that there are no live cells associated with this. Really key, because you'll hear some physicians or chiropractors describe that why, if you're older or middle-aged, that you shouldn't utilize your own cells. You can utilize amniotic or umbilical cord cells because there'll be more cells involved in that. That is not actually true. Essentially, if you take if you take amniotic or umbilical cord tissue, if it's living, there are certainly more stem cells in that. The thing is that the way that is processed does not result in any live cells. Once that tissue has been taken after birth, the companies that prep this based on FDA guidelines have to process this in a way that ends up resulting in no live cells. They need to first gamma irradiate it, freeze dry it, basically pulverize it into a powdered form, put that into a vial, ship that to the doctor's office where it can now sit for 18 to 24 months. Those cells are then utilized by first rehydrating them with some saline, mixing that around, and then injecting that back into the person. Multiple organizations have looked to see, are there any live cells in those products? And there's minimal to no evidence of any live cells in those products. So if you're getting an umbilical cord or amniotic fluid treatment, or it's been recommended to you, understand that you'll be getting a growth factor injection. You're not going to be getting any live cells injected into you. So it's not a stem cell treatment. IV stem cells, you may have heard about this as well. There's no proven benefit for orthopedic conditions. I would be careful about this. If you're asking about things like heart and lungs or kidneys, perhaps that's helpful. Obviously, I don't have that expertise, but for musculoskeletal conditions and for legal usage in this country, IV stem cells are really not the way to go. So what are the type of treatment outcomes you can expect with a stem cell treatment? Essentially, we're really focused on improving pain and function, frequently even in advanced cases. And that's because we can improve stability, improve inflammation. We can help to jumpstart damaged cells in an area that you're treating. And as a person gets better pain relief and functional improvement, they can then also improve their exercise tolerance, which then helps with strength and support of a treated area. Improving an X-ray or MRI image. For advanced conditions, that is generally unlikely. For certain types of tears, that's possible. For certain types of bone-related conditions, that's possible. I showed an example of where someone with spinal stenosis had improvement. Usually what we're really gauging outcomes on is based on improvement in pain and function. So this is an example of a individual who had lumbar surgery. And as classic fashion, so he's someone that had lumbar laminectomy, L3 to L5 level. He's had 2 surgeries in the past, and he still had chronic lower back pain. His original treatment areas included the ligaments, the facet joints, muscles, and epidural space with his own platelets. So with platelet-rich plasma and platelet lysate, he had roughly a 30% pain improvement. We then decided to escalate to bone marrow stem cell protocol, where we then injected the bone marrow derived stem cells and platelets into those same areas. And he's now at a 75% improvement in pain and function, and quality of life is significantly better. The image on the right is essentially an image of injecting a facet joint. This is a needle. This is a needle in the facet joint, a little bit of contrast in it. And again, injecting those cells into the facet joint has made a significant benefit in terms of his improvement in pain and function. Can we treat more advanced conditions, bone-on-bone arthritis, for example? And really, the simple answer is yes. Treatment of advanced facet joint arthritis on average can still get a 70% improvement. Again, understand that arthritis is a biologic condition that is treatable with orthobiologic treatments. There are some caveats. Number one, I would say if you have more advanced arthritic issues, always worthwhile trying platelets first, but if it's not enough, bone marrow-derived stem cells may be required. In addition, our expectations are really more about pain and functional improvement. Improving imaging is likely unlikely. Improving imaging is unlikely. So disc disease. Degenerative disc disease is essentially a degenerative condition where you have progressive stress on the multiple different structures of the lower back. and it can lead to changes in the disc as well, but it also leads to facet joint arthritis, ligaments that leave the area unstable. And again, important to treat all the pain generators, and you can get a good degree of pain relief. There's no need to inject into the disc in that case. If somebody has discogenic pain, let's say a herniated disc or torn disc, they're young, limited other pathology, their symptoms fit with that, you can consider an intradiscal injection where you're then injecting into the disc itself. You should treat other extradiscal or other areas that may be involved as well. A colleague of mine, Dr. Orlando Landrum, assists with that in the office, and that can be helpful as well. Usually, we're still recommending treating those other areas first before injecting into the disc. Injecting into the disc is a little bit higher risk than injecting into the rest of the spine, but can be still helpful in the right kind of cases. Image guidance. Image guidance is essential. As I mentioned before, you need to be using high-level X-ray and ultrasound guidance for all these treatments. I have colleagues who tell me that based on their experience, they can inject areas blindly. I think that is nuts. Number one, you need to be very precise with where you're injecting things. Injecting into an SI joint, for example. To place that properly, you need to really be at a millimeter, sub-millimeter level to actually see contrast in the SI joint. To inject into the epidural space, doing that blindly does not make sense. It's just unsafe. And to inject into a facet joint, it's a very small little joint. To really properly inject into that, you need to make sure you're hitting the area properly. When you're injecting your own cells in particular, it's not good enough to be close to the area. It's not good enough to be around the area. You really have to be dead on in that right space if you want to get the right kind of result. So I mentioned before, how do you know if your physician is a regenerative medicine specialist? Here are a few things that I would recommend looking for that I think are critical if you really want to make sure you're working with the appropriate specialist. Number one, they need to be focused on musculoskeletal issues only. Again, if your physician is injecting Botox on the side, treating a couple other things on the side, and then comes to you to treat your musculoskeletal condition, that's not the right way to do this. You want someone who's really focused only on your orthopedic condition. Number two, they really should be focused on non-surgical treatments. Surgeons, while they have skills in surgery, their skills when it comes to image guidance are not adequate, and they don't have the right regenerative medicine mindset when it comes to these kind of treatments. They look at this differently. They look at cutting out tissue and replacing tissue as the goal. That's very different than what we're trying to do, which is trying to optimize tissue and trying to optimize stability, inflammation, neuromuscular health. Really, your physician should only offer safe and effective treatments. A lot of pain physicians have started to offer these treatments, and unfortunately, the way they'll present it is, well, they could do a steroid injection or a nerve block, or here's this other option. That's not the right way to do this. If you know what is the number one best option, that's what you should be offering your patients. And so your physician should not be doing steroid injections on the side. They shouldn't be offering you chronic pain medications. That's not the right way to treat this. They shouldn't be burning tissue, which is another common way that some of these lower back issues are treated. Number four, they should give you a sense for, are you a good, fair, or poor candidate? What I find is that a lot of times physicians may tell a patient that they're a poor candidate because they have an advanced chronic condition, but they don't actually understand what the data shows, which is that for most musculoskeletal conditions, most, not all, but most, that even if somebody has advanced arthritis or advanced damage, that they can still get good amount of pain relief and functional improvement with a regenerative medicine treatment. And it's a lack of understanding of that data that can lead to that kind of confusion or ignorance. Number five, they should be actively collecting and publishing data. Important. One of the really great benefits of being in the REGENXBIO network is that we're able to collect data, which is then published in larger scale studies, which then help to guide us when it comes to how we're treating patients, and then also help to guide us when we're actually giving recommendations to patients. Number six, you have to use image guidance for all treatments. That may sound obvious when you're looking at these images, but that is not how most physicians actually treat patients. They're still doing things blindly. Image guidance is a must. Again, I don't have X-ray vision. I do, however, have X-ray and ultrasound in the office, which helps make up for that. Number seven, understand how to treat instability. And so the way that you know if you're treating instability correctly is the following. If your physician says he's going to treat condition X for you, but he's only giving you one injection and he's not treating all the other supportive areas, you're not getting a proper regenerative medicine treatment. That's a really key way to figure that out. Number 8, your physician really should know the exact concentration of platelets that they're injecting and stem cell count they're injecting. If they're not actively doing that or understanding that, then they're really not an expert in this. That's not just an academic thing. That makes a big difference in terms of treatment. If your physician does not understand why injecting a low concentration of platelets is less effective than injecting a high concentration of platelets, they're not an expert in this. Number 9, understanding the different orthobiologic products. If your physician is recommending an amniotic or umbilical cord product instead of a normal bone marrow stem cell treatment, because they're telling you that there's live cells and higher cell counts, they don't understand the evidence and they don't understand what they're doing here. You need to be careful then. I would recommend going elsewhere for your evaluation and treatment. And they need to understand why they would recommend one orthobiologic treatment like platelets versus bone marrow and when it's worthwhile actually escalating. And they need to understand how you combine those kind of things as well. So regenerative medicine treatments offer safe and effective solutions for your pain. Again, any questions, please leave them in the chat section. So common questions that I get. Is this too good to be true? It's a great question after this kind of presentation. Understand that there's evidence in the Regenexx network for effectiveness of these treatments going back to 2005. In the overall regenerative medicine field, there's evidence from Dr. Hernegue in France that goes back to actually the early 90s. My own personal experience has been since 2008. And while I can tell you that this is a rapidly developing field, it's not new. You'll find physicians who'll say that this is too new of a field to really give recommendations. That is not correct. The amount of data that's being published, and in particular over the last 5 years, is exponentially more than what it was 15 years ago. And there is enough evidence to give patients appropriate guidance in terms of whether they are an appropriate candidate, what they can expect from treatment, and how well they can expect to get. Understand that there are definitely right and wrong ways to do this. And those are some of the things that I've talked about before. If your physician doesn't know those kind of right and wrong ways, that's not an expert in this. Next, you need to have expectations that are grounded in reality and evidence-based medicine. If your physician's giving you pie in the sky expectations, if you haven't been able to run in 10 years and your physician has told you you'll be able to run and do cartwheels, that's not really reasonable expectations. And as crazy as that sounds, I've actually heard a patient tell me that their original physician told them that's not really grounded in reality. So your physician needs to give you conservative, realistic expectations. How long do results last? So Regenexx data goes up to 10 plus years. Data from Philip Hernegue, he's got data that goes over 20 years. What I tell people, however, is think conservatively. For a chronic condition, expect that you'll need a repeat treatment at some point, possibly a few years after initial treatment or earlier, depending on how well you're getting. My general recommendation is after treatment, you'll have more inflammation up front, some stiffness for the first couple of weeks. You should be getting improvement at the 4 to 6 week mark. And I generally like to reevaluate at the 2 to 3 month mark. If you're continuing to improve, you give it a few more months to see how well you're going to get. And at some point, if you're starting to plateau in terms of improvement and you haven't reached your goal, then you would repeat a treatment at that point. I think the best way to maintain results after treatment include improving your biomechanics, focusing on corrective exercises, bracing if needed, taking the appropriate joint healthy supplements, and repeating treatment is generally additive to the initial treatment if required. The general idea being that there's a stair-step approach to improvement with regenerative treatments. As you get reset at a higher baseline, a second treatment then puts people at a even higher baseline long-term. Cost. So these treatments are not routinely covered by insurance. Some exceptions include the following. There are self-insured companies, which is essentially the majority of large companies in this country, that can add this to their benefits plan. If you fall into that kind of category, consider connecting with REGENXcorporate.com. They have the experience of talking to talking to companies and getting that added to their benefits plan. Some other insurances that may be covering, Medicare does not routinely cover this. The military insurance TRICARE has started to cover platelet-rich plasma in certain cases, namely knee arthritis and elbow tendonitis. So progressively, insurance will start to cover. However, it's not. Current cost estimates in the United States, platelet-rich plasma generally starts at $1,500 to begin with. Stem cell treatments generally start at $6,500 to begin with. Keys to determining value. Number one, make sure your physician and clinic are regenerative medicine experts. Make sure you're receiving a real stem cell treatment, not a bogus amniotic or umbilical cord product. And understand that these are in-office procedures. You can avoid expensive hospital and surgery center fees that frequently get added on. Lastly, I didn't mention this, but generally HSA and FSA plans do offer coverage or do offer reimbursement if you have that as an option as well. So just as sort of a FYI, the way I generally approach patients when they come in with chronic musculoskeletal issues, our approach here in Chicago Arthritis and Regenerative Medicine, we're focused on non-surgical treatments for your arthritis, tendonitis, injuries, and back pain. Evaluation includes evaluating for inflammation, instability, asymmetry, neuromuscular issues. Generally, first-line recommendations are correcting with low-risk intervention, exercise, and supplements. If that's not working, then escalating to regenerative medicine treatments, using the best quality products from your own body, a plan that is specifically tailored for your own condition and needs, and delivering those cells using the highest level image guidance available. By the way, I do see questions, and I will certainly answer these. Somebody asked, they've had a few lidocaine injections, and they have some more that are scheduled, as well as possibly a nerve ablation. Yeah, again, as I mentioned, the issues with the ablation procedures is that while they can give pain relief, the problem is that the nerves that they're basically burning, that they not only provide sensation to the facet joint, but they also offer motor or strength and control of the multifidi muscles around that spine as well. And so if you're burning or damaging those nerves, then you can also then lead to weakness in those muscles as well. That'll lead to more instability long-term. I would strongly recommend avoiding nerve ablation if possible, just because I don't think it's the right long-term thing for anyone who's got chronic back pain. All right, another good question. Is this procedure effective for cervical disc degeneration? Shorter answer is yes. While I do not specialize in neck issues, I have a colleague, Orlando Landrum, that does, who works in the office as well. And that is a really great option for neck issues, mainly because the treatment options for neck are really not great. And losing mobility in the neck from a fusion surgery or getting frequent steroid injections into the neck is just not a good option. And I think really regenerative medicine is very much a breakthrough for spine issues in general, and certainly for lower back issues. But I think for really cervical spine, neck issues, I think it's there's just so little options for patients with neck issues. I think it's a very hopeful and encouraging option for a lot of patients who've got chronic cervical disc degeneration. Another question was, how do I get evaluated? So on your screen, you'll see a quick and easy way to get access to my online scheduling system. Essentially, by clicking on that icon, you should be able to schedule a telehealth evaluation fairly quickly and easily. We are doing in-office evaluations as well. We're trying to do most of this via telehealth at this time, mainly for safety reasons. Okay, another great question. Will this work for spinal stenosis? Absolutely. I showed a picture earlier on where an example of someone with spinal stenosis and not only improvement in pain and function, but actually improvement in his MRI as well. The keys for spinal stenosis are to treat not only the nerve that's being compressed, but all of those ligaments that offer stability and if you can strengthen and improve them with treatment, you can actually take pressure off that part of the spine that's being compressed. You have to understand that the difference between a few millimeters is a big deal when it comes to your musculoskeletal system, in the sense that if you have spinal stenosis, if that compression is even lessened by a couple millimeters of stress, by strengthening the supportive tissues around that, you can make a huge difference in terms of pain. In addition, if that nerve is actually chronically irritated, by injecting your own platelet growth factors, which is called platelet lysate, around the nerve, you can actually help to reduce some of the chronic inflammation and pain that's coming from that nerve as well. And so absolutely, spinal stenosis can be treated, and it's a very nice treatment for spinal stenosis as well. Wonderful. Any other questions at this time, please put them up. As a reminder, my name is Siddharth Damber, work at Chicago Arthritis and Regenerative Medicine. If you're interested in making an evaluation, there's a quick and easy button to click there that'll take you to the online scheduling system that can help to expedite that. I personally think that regenerative medicine is not only the way of the future, but it is what works right now for chronic and even some acute musculoskeletal issues. And in my own personal experience since 2008, being involved in this field, I can tell you that things have come a long way, not only from a evidence standpoint, but from an understanding standpoint. And what's nice about this field is that it's moving quite fast in terms of our understanding of how to get better outcomes. And if you pursue this appropriately with someone who's appropriately specialized and focused on these kind of treatments and conditions, I think this can be a huge benefit in terms of people's pain, function, and quality of life. Well, if there's no other questions at this time, I will start to wrap it up. I'll leave the webinar on for a few minutes. If anyone needed to click on that appointment button, you'll receive an email later on if you wanted to replay this or have a friend or family member rewatch it as well. And if I or my office can be of any additional assistance, please feel free to call or email us at any time. And if we're able to assist, I look forward to meeting soon in the future. Until then, I hope everyone has a good day and live well. Bye-bye.